We welcome you to Infectious Insights, a case series designed to discuss challenges and offer solutions for difficult-to-treat gram-positive bacterial infections. What is the economic benefit of prescribing Telavancin in this patient?
So it's an excellent question. One of the reasons that people sometimes shy away from Telavancin is that it is an antibiotic that is a branded antibiotic and it has a higher initial acquisition cost. The pharmacoeconomic modeling, which has been done, and looking at Telavancin, has shown that despite the fact that the upfront costs of the drugs are higher versus something like vancomycin, that you make up some of that additional cost and actually oftentimes end up in a better situation because of shorter length of stay in the ICU, shorter total length of stay in the hospital. And it should also be noted that Telavancin in the original ATTAIN studies was shown to have a higher cure rate for patients, especially with monomicrobial Staph aureus infections, MRSA or MSSA, or those with MICs of 1 or greater. So when you take the increased likelihood of cure combined with decreasing ICU stays and decreasing overall hospital stays, then the incremental increase in the cost of the antibiotics or potential small incremental increases related to some acute kidney injury are overcome again, by that savings in the length of stay. So we're able to justify that what looks like a more expensive drug actually from a hospital system standpoint can often become the less expensive choice. But this does involve thinking differently. It really means that you have to think from a global standpoint, not just from the specific budget of the ICU service line or the pharmacy service line, but thinking about how does this overall benefit my patient and how is this affecting the overall cost of care for that hospitalization?
You mentioned nephrotoxicity and how even if the patient does have some nephrotoxic adverse effects, that this cost benefit is still there. Do you want to speak a little bit more about your concerns with acute kidney injury with Telavancin?
So Telavancin is a glycopeptide antibiotic, and it does have a small risk of acute kidney injury associated with it, as has been shown in the studies. Now, part of this is it's an antibiotic that is used when patients are at a point in time with a septic type picture like we're seeing that we will see a fair amount of acute kidney injury. A study was done looking at renal shifts, again, taking the data from the ATTAIN trials, where they compared vancomycin and Telavancin for the treatment of pneumonia. And one of the questions was, what was the impact of acute kidney injury? And one of the key things to realize from this is that acute kidney injury in the trial can be assessed whether you're talking about a very small increase in creatinine or more substantial. So they looked at the time to changes in creatinine levels as well as the degree of that change, looking at the estimated creatinine clearances. And what they found was that while Telavancin had earlier shifts seen, they tended to be present by day 4, and this is likely because the Telavancin is distributing and becoming active a little bit faster throughout the body. Most of those shifts tended to be the lower grade shifts of just a few milliliters within creatinine clearance changes. And when you looked at the totality of the changes, while the overall number of patients with acute kidney injury was very similar between the Telavancin and vancomycin groups, the vancomycin groups actually had more patients that had high-grade renal shifts, which was a greater decrease in their overall kidney function that was seen at the end of therapy. And this is something, because of the way vancomycin works, you'd get a little bit of an accumulation over time, and it tends to take a little longer for these renal insufficiency or acute kidney injury to show up.
In this patient, how would you monitor for acute kidney injury?
Yeah, I think that is one of the most important things to realize is that we can manage acute kidney injury if we are aware of it with any drug that has potential to cause it. On an inpatient dealing with an acute illness where the idea of dynamic changes in renal function is actually more common than not, what you want to be doing is monitoring your creatinine clearance or your creatinine level on a daily basis until that patient has really gotten to a very stable and baseline level. And if you do daily monitoring, then doses can be adjusted in real time if you're starting to see changes. Sometimes the change is that patients become hypermetabolic, and sometimes you see the acute kidney injury. So the monitoring to ensure that we are keeping patients with appropriate and therapeutic dosing becomes key. As you're getting to, say, the latter part of this patient's stay, they're out of the ICU, they've stabilized on the floor, you might be able to back off to, say, every other day. But on a hospitalized patient, I would probably say at least 3 to 4 times a week, if not daily, depending on the clinical situation.
Thank you. Is there anything else, Dr. Jacobs, that you would like to add about this case?
Again, I think the key thing when I think about this patient with a hospital-acquired pneumonia is, what am I going to do to most quickly treat that pneumonia? Because I want to minimize the amount of time that my patient needs to be on a ventilator. I want to prevent that if I can and keep that time short, which means I really need to have drugs that are getting in quickly and effectively with the appropriate spectrum. And again, so in this case, the one thing that I think we may not have covered as much, but is really important for our audience to realize, is that one of the benefits that Telavancin brings is it has excellent and very rapid penetration into a lot of different sites within the body, and very specifically in the lungs. The level of Telavancin that is achieved within the lungs within a day or so of that first dose, when you're looking at alveolar macrophages and epithelial lining fluid, can be anywhere from 10 to 70 times higher than the MIC that we need to achieve, which means we are getting an antibiotic into the location of the infection at very high levels, which are more likely to get excellent bactericidal killing. Unfortunately, when we're dealing with vancomycin, even when that drug is at what are considered therapeutic blood levels, there is incredible variability in the amount of penetration into the lungs. Sometimes these are therapeutic. Sometimes those levels are below the MIC values that are needed to get efficacious treatment, which brings me to the thought that if I'm treating my patients, I want to make sure my patient's going to be getting a good, active, and effective antibiotic on day 1. Because if my antibiotic's not effective until day 3 or day 5, then my patient's going to have a worse outcome.
Thank you, Dr. Jacobs, for your clinical insights on this case. And thank you all for joining us for Infectious Insights. This Infectious Insights series is brought to you by Cumberland Pharmaceuticals.